Hello friends, welcome back to my channel Medicine Hub on 01. Today we'll talk about mitral valve prolapse. Okay, so before starting the topic, let's know what are the normal things, or we can say under normal physiological circumstances. Now see, what do we mean by the prolapse? What do we mean by prolapse? Prolapse means, for example, if I say it over here, this is the what? Left atrium, this is the left ventricle, this is the what? Mitral valve, right? Now, whenever we will see that try to understand during the isovolumetric contraction, during isovolumetric ventricular contractions. So, whatever the thing we'll see within the ventricle, the pressure that will keep on rising, right? So, if you write it over here, during isovolumetric, isovolumetric, iso, okay, volumetric ventricular contraction, what type of the thing we see over here? See, in these cases, as we know, at the time the aortic valve that will be also closed, as well as the mitral valve that will be also closed. So during mitral valve, during the left ventricular contraction, whatever the thing we'll see, the blood that will be, okay, there is a chances for the blood to go back from the from the left atrium to the left ventricle. But what do we know? Whenever we will see the contractions of the left ventricle at that time, as we know that the what? There's a left, we can say the mitral valve that goes. As a result, the blood that will be not able to go from the left ventricles to the left atrium. Along with that, whatever the others structures that will get over here, that will also prevent the backflow from the left ventricle to the left atrium. Whatever the structures we can get over here, let's draw them. Now, as we know, in these structures, we'll get another type of the structures. Okay, let's draw it properly. We'll get another structures that will also inhibit the, backflow. Okay, so we can write it over here. There's these structures. These are the structures that we will get over here. In a nutshell, this whole structures, and I have just drawn over here, that is known as mitral valve apparatus. Along with that, as we know, within the mitral valve, we'll get the fibrous annulus part also, the fibrous annulus ring. Okay, on which we'll get the two leaflets in terms of the anterior leaflets and the posterior leaflets. Those are attached. So in these cases, if we say that, okay, so this mitral valve apparatus, that will prevent the backflow, or you can say prevent the bulging of the, see, this will prevent the bulging of the what? This will prevent the bulging. Normally try to understand whenever the left atrium, that is what, the left ventricle, the left ventricle that is contracting, at that time whenever the pressures within the left ventricle that will keep on rising, so it will, the same pressure that will be applied also within the mitral valve. So there is a chance. Normally try to understand, normally the mitral valve, they are closed in this way. Now whenever the pressure within the left ventricle that is keep on rising, at that time there is a chances for the what, mitral valve to bulge out, to bulge upward, right, to bulge upward. Now this structures you can say over here, this is the what, this is the chordate tendon, this is the what, papillary muscles. Okay, this will inhibit the what, bulging out of the mitral valve upward. So these whole structures from here, from the fibrous part of the fibrous ring of the mitral valve to the whole structure, that is known as what, mitral valve apparatus. See over here, another structure, another thing we'll see over here. See, if we see the structures of the myocardium, now see, these papillary muscles, they are also connected with the, what, the myocardium part. So within the mitral valve apparatus, okay, that will prevent what, that will prevent the bulge out of mitral valve. Now, what are the components we'll get in terms of the mitral valve apparatus? Within the mitral valve apparatus, the first thing we'll get what? The first thing we can write over here, the myocardium part. So the myocardium on which we will see the papillary muscles are attached. So within the mitral valve apparatus, we'll get the various components, but one of the components we can write it over here. That's the what, myocardium part on which the papillary muscles are getting attached. So you can write it over here, the myocardium on which papillary muscles attached. The next component, the papillary muscle itself is the component of these papillary muscles. This itself is a component of what? It's a component of mitral valve apparatus. So we can write it over in the next component, the papillary muscle itself. The number 1 is number 2, papillary muscle itself. The third thing we can get over component we are getting. After that we will get this is the chordae tendon, right? This is the chordae tendon. And the fourth component will get what? Within the fourth component we will get the valvular leaflets, right? We will get the valvular leaflets. If you saw the structures over here, we will get the two components from here. Try to understand. We will get the anterior leaflet as well as the posterior leaflet, right? We will get the anterior leaflet, for example, this is the posterior leaflet. So we will get the fourth component what? The valve leaflets. The valve leaflets. And the fifth component we will get over here. That's the, see, there's the what? Fibrous ring. This is the fibrous ring of the valve. So you can say the fibrous annulus ring. Fibrous annulus or ring. This whole thing that will inhibit the bulging out of mitral valve upward. That means within the left atrium. So this whole mitral valve apparatus in terms of the myocardium, the papillary muscle, the chordae tendon, and then what? The valve leaflets and the annulus ring. This whole structure in a nutshell, we can say the mitral valve apparatus that will prevent or that will inhibit the bulging out of the mitral valve towards the left atrium. Okay. So if we get any kind of the problem in the whole component, in all components, any of the components, if we get any kind of the problem, for example, if we get the papillary muscle rupture, or if we get the chordae tendon rupture, so whatever the problem we'll see, whenever we will get, okay, before that let's draw these parts over here. I think it will be more clear for you guys. So if we just draw this whole structures over here, the mitral valve is the ring, we will get the leaflets over here, we get the leaflets. Now we will get what is the chordae tendon, and is the papillary muscles. In the same way, we will get the chordae tendon, and we will get the, along with we will get the myocardium that is getting attached, right? Myocardium that is getting attached over here. Now this is the whole component of what? This is the all components of, we can say, the mitral valve apparatus. Okay. Now see, if we get any kind of the problem over here, okay, if we get any kind of the problem over here, then, okay, for example, if we get any kind of the problem, within the, for example, we are getting the chordae tendon rupture, I am writing chordae tendon or rupture. If we get chordae tendon ruptures, or if we get the papillary muscle rupture, for example, then whatever the problem we see, normally, as I said you before only, that whenever the left ventricle that is contracting, at that time there is a chances that as the pressure that will keep on rising over here, the same pressure that will be also applied within the mitral valve. So whenever the pressure that is keep on rising, as a result we will see over here, there is a chances for the mitral valve to prolapse or to get bulge out towards the left atrium. Now these whole components of what of mitral valve apparatus that will inhibit, that means that will not let the mitral valve to prolapse inward, that will not let the mitral valve prolapse upward in terms of the what? Left atrium, towards left atrium. Okay. Now if we get any kind of the problem in these things, for example, if we get the chordae tendon rupture, we get, if we say in terms of the papillary muscle rupture, at that time whenever it will contract, as a result we will see these things. Okay, try to understand, whenever the left ventricle is contracting, along with that, whenever it will contract, the same time we will see also the contractions of the what? Papillary muscles, contractions of the chordae tendon. Now whenever, see, if we get these ruptures, the ruptures of these muscles, papillary muscles for example, whenever it is, whenever we are getting the ruptures, at that time whenever the left ventricle that will contract, as a result it will be functionless, we will get the dysfunction of the papillary muscle. So there is a chances this pressure that will be transmitted over here, and there is nothing to, just to intact the left, we can say, the mitral valve in its positions, because whenever the papillary muscles, or if you say the chordae tendon, that is dysfunctional, empty the pressures that will be applied over here, and there is nothing to inhibit the mitral valve to go, that will not, there will be nothing to inhibit these things, to inhibit the mitral valve to prolapse inward. That means to go where in towards the atrium, left atrium. Okay. So if you get this type of the structures, or you can say the chordae tendon rupture or the papillary muscle rupture, at the time we will get this type of the problem. Okay. Now whatever thing we'll get over here, whenever we'll get this type of the problem, And whatever thing we'll see in this case, let's try to understand from another figure. See, in these cases we'll get whatever the problem. Let's draw it over here, guys. Okay. Okay, it's the one part we'll get. Let's draw it properly, guys. Otherwise, okay. See, from here we'll get. Okay, so we'll get the bulging of the posterior leaflets. In most of the cases, we will get this type of the problem in the young, in the young female, around 15 to 30 years old. In these cases, we'll get, and the most, the most chances for involving in terms of the leaflets is the posterior leaflets. The posterior leaflets that is having the more chances to get involved over here. Okay. Now, whatever thing we'll get in these cases, try to understand. For example, we have got the ruptures over here. It's not functionous. So we are getting the bulging about this whole thing over here. Now, another name for it, the mitral valve prolapse, or you can say for this another name for it, what that is also known as Barlow's syndrome. Barlow's syndrome. Another name for it we can say also, puffy. We can say. Okay, let's write it over here. Floppy mitral valve. Yes. You can say another name for it. Floppy. Okay, let's use different color for it. Then I think the different color it will be understandable more clearly. So another name for it that is known as floppy mitral valve. Okay. Now we got up to this one that we got already over here. This is the what we are getting the dysfunctions within the the different kinds of the muscle in terms of the quad tendon in the papillary muscles. As a result, we are getting the bulging up on these whole structures. Now, what are the regions that can just do the bulge up all these things? Okay. Now, as far as the etiology is concerned, whatever thing we'll get in this case, just try to understand from here. What are the factors that can do this type of thing? Now, if we see the structures of the valve leaflets, if we see the structure of the valve leaflets over here, for example, I'm showing you guys in the valve leaflets. For example, I'm showing these portions over here. We'll get the rings, and within the rings we'll get two types of the structures. Now within the valve leaflets we'll get this structures. The inner structure that is known as fibrous zona. Okay, or you can say zona fibrosa. This inner structure that is known as zona fibrosa. Zona fibrosa. Outermost structure that is known as zona spongiosa. Zona spongiosa. Now, if we get any kind of the problem, for example, for whatever the regions, okay, if we get the problem at the level of the zona fibrosa, if we get the dysfunction of the zona fibrosa, definitely we will be not able to inhibit the bulging up of the valve leaflets to go from what? From the inward to outward in terms of the towards the left atrium. Okay. Now, whenever we are not able to inhibit these things, so whatever the problem we'll see, okay, and what are the etiologies we can see in these cases. See, in these cases we'll get basically it's the it is known as idiopathic, but documented things that is known till today. There is we will get over here the myxomatous degenerations, myxomatous degenerations of what? Of this body structure. That means the zona fibrosa. Okay, that will just cause the degeneration of what? Degeneration of zona fibrosa. It's on etiology, you can say over here. Okay, basically we'll get the development of the different kinds of the tumor over here. Okay, from the terms it is easy to understand. Myxedoma. Okay, myxedomas. So myxedomas, we can say the degenerations that will cause the damage over here. And most of the cases we'll get in this case. Another thing we can say that is the genetical problem you can say in terms of the Marfan syndrome. So Marfan syndrome, whatever the thing we'll see in these cases. In Marfan syndrome, as we know, the type 3 collagen is present over here. Is the type 3 collagen, as we know. In these cases, we will get the mutation over here within the chromosome number 15. So within the chromosome number 15, we will get the mutations, and as a result, we will get the production of the defective protein that is known as fibrillin on. So whenever we'll get the fibrillin on is the defective protein. So whenever you're getting the fibrillin on, that is a defective protein for the mutations on the chromosome number 15 gene. Okay, as a result, we'll see in these cases the type 3 collagen that will be loose. See the type 3 collagen, whatever the structures will get over here, the type 3 collagen that will be loose. So we'll get the loose type 3 collagen. So definitely they will be not able to inhibit the prolapsing of the mitral valve. Okay, in these cases. Now what are the other things or the etiologies we can say over here? If we get, for example, if we get the very long, try to understand the chordae tendoni, that is also responsible for, if you write it over here, the very long chordae tendoni. Now in these cases, whenever they will be very long, definitely there is a chances they will be not able to do functions properly. And the next thing, if we get the large fibrous ring, try to understand whenever you are getting the large fibrous ring, they are just what? Whenever try to understand, whenever after the completion of the contraction of the left ventricle, they will come towards each other, mitral valve will be closed. But whenever we will see the valvulets, leaflets, or you can say the fibrous ring, that will be large. As a result, the chances for the prolapsing, that will be increased. Whenever the size is getting increased, definitely the chances of the bulging out, that will also increase. So you can write it over here. Another thing, that large fibrous ring, okay. And the last region we can see over here, that papillary muscles dysfunctions. If we get any kind of the problem within the papillary muscles dysfunction. So these are the causes you can say that can leads to develop of the mitral valve prolapse. These are the regions that can develop the mitral valve prolapse over here. Okay. Now we'll talk about the other aspects in terms of the different kinds of the examination findings. Okay, and different kinds of the other regions that can cause also the mitral valve prolapse. So what are the other regions over here? So as I said, in these cases, as we know that hypothyroidism. So hypothyroidism, where we will get the lower T3 and T4 level, that can also cause the what? Mitral valve prolapse. Along with that, if we get the rheumatic heart disease, where we will get the vegetations around the valve leaflets, right? That can cause also the mitral valve prolapse. And we can say the ischemic heart disease. And another one, if we get the write it over here, hypertrophic obstructive cardiomyopathy. If we get the development of the hypertrophic obstructive cardiomyopathy, that can also leads to the mitral valve prolapse. How? See, in these cases, what type of the thing we know? In these cases, as we know, there will be the septal hypertrophy more in these cases, right? In these cases, we'll get the septal hypertrophy more. Okay. So whenever we get the septal hypertrophy over here, we'll get the hypertrophy in the whole in whole structures of the left ventricle, but within the septal things, within the septal regions, we'll get the more hypertrophy. But whenever the hypertrophy that will be more in these regions, try to understand, whenever the ventricle that will contract, that will apply much more pressure, right? So this much, there will get the development of the pressure that will be too much. So whenever the pressure will be too much over here in terms of the hypertrophic obstructive cardiomyopathy, try to understand what I am saying. I am repeating once again. So if we see the development of the hypertrophic obstructive cardiomyopathy, in these cases we will get along with the what? Along the line of the septal line, along the line of the septal regions, we can say in the septal regions we will get the more hypertrophy. So whenever we get the more hypertrophy within the regions where in the septal regions, along as a result we will get the pressures during contraction that will be increased, and these pressures that will be transmitted towards the mitral valve. So whenever the pressure that will be pushed towards the mitral valve, definitely there is a chances for the development of the mitral valve prolapse. Okay. Now other things we can write it over here, the atrioseptal defect. That can cause also the mitral valve prolapse over here. Okay. Now see what type of the other things we'll get. Before that, let's repeat once quickly. So what are the reasons? What can cause the mitral valve prolapse? So you have said it over here already. That the hypothyroidism. Then I said the rheumatic heart disease. Then I said what? The ischemic heart disease that can cause also the mitral valve prolapse. Along with that, the most important one you can say over here the hypertrophic obstructive cardiomyopathy. And the last I said the atrioseptal defect that are also responsible for causing the mitral valve prolapse over here. Okay. Now we'll take out what about the the other findings we can get in terms of the heart sounds, different kinds of the murmurs. Okay, we'll talk about all these things right now. So let's draw it over here and try to understand this thing. Now see, whenever you're getting the development, try to understand whenever you're getting the development of the what, whenever you're getting the development of mitral valve prolapse, whenever this will contract, okay, whenever the left ventricle that will contract, these pressures that will be applied where within the valvular plates, that is what try to understand whenever the valvular plates that will go towards the heart sound. What do we know normally? The heart sound we know this is the, for example, this is the ventricular systole and this is the ventricular diastole. For example, the ventricular systole, the ventricular diastole. As you know that at the beginning of the ventricular systole we will get what? The closure of the mitral valve and the tricuspid valve. As a result, we will get the productions of the first heart sound, right? Here we will get the productions of the first heart sound, the S1. We can say mitral and tricuspid valve closure. And at the end we can say we will get at the end stage of the ventricular systole we will get the S2. We will get the closure of the aortic valve, pulmonary valve, A2, P2. Okay. Now see in the mid, if we see in the mid systole, in mid ventricular systole, in mid ventricular systole, whatever thing we will get, try to understand from here. In mid ventricular systole, see whenever the vein contractions within the ventricle that will be severe, that will be much more. As a result, we can see there is a chances for the backflow that will be increased. So whenever the backflow we see that we, in terms of the mitral valve prolapse that is getting increased, as a result we can hear one type of the word sound that is known as mid systolic click. That is known as mid systolic click. Okay. So what mid systolic click? Let's draw it over here. So yes. So in the mid of the ventricular systole, at the mid and the mid of the ventricular systole, in terms of the mitral valve prolapse, whenever the mitral valves they are bulging out, as a result, the pressures within the mitral valve during ventricular contraction that will be increased. So you can hear one type of the sound that is known as what? Mid systolic click. So you can represent the mid systolic click in the mid. So okay, we can represent this whole things over here. So this is known as mid systolic click. Mid systolic click. So you can write it over here. The mid systolic click. Now, if we see that the prolapsing things over here, there's a severe. If we get the severe prolapse over here, or if we see the severe damage where within the valve regions over here. So whenever the problem that will be severe over here, try to understand whenever the left ventricle that is contracted, as a result there is a chances for the development of the mitral regurgitations. So whenever we get the problem over here, you guys, whenever we see the problem that will be severe in the level of the valves over here. So whenever the bulging out tendency that will be increased in terms of the mitral valve prolapse, in these cases sometimes we can see the mitral valve regurgitations, the backward blood flow. Whenever we see the development of the mitral valve regurgitations, whenever we get the the backflow, for example we are getting the backflow over here. So mitral valve regurgitations, we can say mitral or regurgitation. If we see the severe problem, at that time we will see also one kind of the sound that is known as late systolic murmur. That is known as late systolic murmur. Now when you will hear the late systolic murmur, let's draw it over here. So it's known as what? It's the late systolic murmur. Late systolic murmur, guys. Okay. Now, okay. what did I say you? That the pressures that will be increased over here, try to understand the pressures that will be increased, and as a result the pressures that will be transmitted towards the what mitral valve, then there is a chances if you see the problem in this level in terms of the cardiac tendon or in terms of the papillary muscles or in terms of the I have already said the large, if you get the large if you get the large fibrous ring over here, as a result we will get the chances for the development of the bulging out of the mitral valve towards the left atrium, that is known as what, mitral valve prolapse. Now if we see the pressures within the left ventricle that is increased little more, if we see the pressure that is getting increased little more within the left ventricle than the mitral valve prolapse pressures over here, then as a result we can hear one more sound that is known as late systolic murmur. So at the end of the ventricular systole, at the end of the ventricular systole, we can hear the late systolic murmur. So at first, in between S1 and S2, we got what, mid systolic click. If we see within the ventricle, the pressure is getting increased a little bit more. As a result, we can hear another kind of the sound that is known as late systolic murmur. In this cases, we will get the development of the mitral regurgitations. Okay. Now, what are the problem we'll see whenever we are getting the development of the late systolic murmur, there is a chances or the risk for the development of or risk of thromboembolism. So in these cases we will get the risk for the thromboembolism that will be increased. Along with that, in these cases we will get another risk that you can get the infective endocarditis. Infective endocarditis. Did you understand these things? What I am saying, you guys? Try to understand what did I say you. At first, why we will get the mid systolic click. After the mid systolic click, we will get the what? We will get the late systolic murmur. If you see the pressure that is getting increased more than the left, mitral valve prolapse. If the pressure is getting increased little more, as a result, we will get the late systolic murmur. Productions of late systolic murmur. Now, what are the risk factors? In this cases, we can get the thromboembolisms. We can get also the infective endocarditis. Okay, hope it's clear. Okay, now we'll talk about the clinical manifestations of these things. Okay, the clinical manifestations. So, what about the clinical manifestations we will get in these cases? Let's talk about all these things. Okay. Now, if we say in terms of the clinical manifestations for that thing, let's Now, in terms of the clinical manifestations, whatever thing we'll get in these cases, in most of the cases, in terms of the young females, in these cases we'll get that is asymptomatic. So initially of these things we'll get the asymptomatic. Okay, or we can get the atypical chest pain. We can get the stepping nature. Atypical chest pain. Now, another thing we can get over here, there's the word palpitations. Another thing we can get the palpitations. So palpitations. Okay. So you can get the palpitations over here also. Palpitations mean in ourselves we can say the unpleasant heartbeat. Okay, this type of thing we can get in terms of the clinical manifestations. Now, whatever thing we can get on the examination findings, what type of the thing we will get over here. Let's talk about all these things. How can we just do the investigations? Okay, so if we write it over here, the investigation things over here. Let's write out the investigations. If you do the investigations, if you just do the chest X-ray, if you do the chest X-ray, in these cases we can get the normal. Okay, if we just do the in terms of the ECG, whatever the thing we'll get, in these cases we'll get the non-specific ST segment. We'll get the non-specific ST segment elevations, and along with that we'll get the non-specific TOF changes. We'll get the TOF changes non-specifically. Okay, non-specifically we'll get the TOF changes over here. Okay. Okay, let's write it over here. Okay, let's use this color. So we can write it over here, non-specific changes. Okay, let's continue. So we can just in terms of the investigations, we can do the chest X-ray. Okay, after within the chest X-ray, basically we can get the normal things over here. But after that we can go for the ECG. Within the ECG, in these cases, you can get the non-specific change in the ST segment and the TOA. But the most important findings as far as the investigation is concerned, we have to go for the echocardiography. Okay, then it's done. Now, if you see in terms of the treatment, at first we use the beta blockers. Okay, after using the beta blockers, if you see there is a chances, if after using the beta blocker, if you see there is a chance, okay, there is chances for development of the thromboembolisms. In these cases, we have to use the anticoagulant therapy. Now, if we see that damaging on the valves over here, at first we have to think about the repairment of the valve. If the repairment of the valve is not enough, at that time we have to go for the replacement of the valve. So what did I say you? That in terms of the treatment, at first, we have to use the beta blockers. By using the beta blockers, if we see there is no proper, we are not getting the expecting result at that time. If we see there is a chances for the development of thromboembolisms, at that time we have to go for the anticoagulant therapy. Now, after using this all things, if we see within the valve there is the damaging on the valve. If you see the damaging on the valve, at first we have to think about the repairment of the valve. If it is not enough, then we have to go for the replacement of the valve. And as far as the investigation is concerned, at first we have to do the chest X-ray. On the X-ray, basically you can get the normal things. And now, as far as the ECG is concerned over here, we will get the non-specific, non-specific changes in the ST segment as well as then the TOA. And at last, the best findings we can do over here is the echocardiography. Okay, so that was all about in terms of the mitral prolapse. Remember this thing in treatment, the first line choice. That in treatment we have to use the beta blockers. After using beta blockers, if you see there is the development of thromboembolisms, then we should go for the anticoagulant therapy. And if we see at last, if we see there is if we see the damaging on the mitral valve, at first we should think about the repairment of the mitral valve. After that, if we see the repairment of the mitral valve is not enough, at the last we can go for the replacement of the mitral valve. Like this, we can do the treatment. So that was all about in terms of the mitral valve prolapse. Thanks for watching.